Hi, my name is Professor Young, and I'm going to be covering the content that we need to know for week 3 in maternal and newborn nursing for Fortis College. So, week 3, we're going to be covering the labor and the birth process. Um, there's a lot of information in these next PowerPoints, so just do your best to stick with me. Take some good notes with the PowerPoint, the copy of the PowerPoint that I included in your weekly announcement. And let's go ahead and get started. So we're going to start by talking about labor and birth process. So whenever we're discussing labor, we also have to discuss factors that can lead to a conducive labor or factors that may impede labor, okay? Factors that affect labor would be your passenger, okay? Passenger refers to the baby as the baby is coming down. Different qualities that the baby may or may not possess is going to affect how labor progresses and how successful delivery is. So the first thing we have to talk about is size of the fetal head. It is important to know the location of sutures and fontanelles in order to determine the presentation, station, and attitude of the fetal head. Sutures are the connective tissues that connect the bones of the fetal skull. Fontanelles are the area where two or more bones meet. Two most important fontanelles are the anterior and the posterior fontanelles, which you guys may be familiar with these. The anterior fontanelle, which we have a picture of the fontanelles in the middle here. The anterior fontanelle is a diamond-shaped fontanelle, which closes 18 months after birth. Fontanelles can also be referred to in layman's terms as soft spots. A lot of moms refer babies to this as soft spots. The other one would be the posterior fontanelle, which is triangular and it closes about 6 to 8 weeks after birth. So that one closes pretty quickly. Okay. So why do we need to know about sutures and fontanelles? Sutures and fontanelles are the structures of the skull that make the skull flexible in order to accommodate the birth passage and infant brain. So as that baby's head is making its way down through the vaginal canal, we're experiencing a lot of squeezing, a lot of constricting of the fetal head, of the fetal skull. If those fontanelles and sutures were not in place, that fetal head would not be able to pass through because there's no way that it would be able to mold to fit the shape of the vaginal canal as we're making our progression down through birth. So, sutures and fontanelles make the skull flexible to accommodate the birth passage and infant brain. Because these bones are not firmly united, slight overlapping may occur, and that is what we refer to as molding. Okay. Molding will help adapt to the size and shape of the maternal pelvis. So when we're talking about molding, we're talking about those bones shifting over the suture lines, shifting over into the fontanelle, not dangerously, we're not perforating anything or damaging anything, but just a natural like shape. Most of the time, this is what we see when babies have cone heads, right? That is just kind of a manifestation of molding, which is something that we need to assess whenever a baby is born, assess their skull. Okay. So, after the other important thing that we need to talk about is that if we rupture membranes, okay, so provider goes in during labor and determines that the mom is progressed enough, or what they would like to do is rupture her bag of amniotic fluid, rupture her water. We as nurses are able to feel where the fontanelles and the suture lines are, and that's going to help us determine the baby's presentation, station, and attitude. So we are able as nurses, and let me tell you, it's not going to happen the first time you perform a cervical exam, maybe not the 10th time, but you will get to the point where you're comfortable enough where you can feel where that anterior fontanelle is or the posterior fontanelle and determine if that baby is in a good and favorable position for birth. Okay. So, moving on to fetal presentation. So, whenever we're using the words attitude, lie, station, presentation, those are all things that, terminology wise, I want you guys to be familiar with because it's going to assist you on your exam and on your quiz and on your HESI exam. Okay. So fetal presentation refers to the part of the fetus that enters the pelvic inlet first and leads through the birth canal during labor. So that's the part that is coming down first, okay? The main three present fetal presentations would be cephalic, which is fetal head, breech, and that can either be footling, where the feet are coming first, frank breech, which is where the butt's coming first, um, or so on, or shoulder. Okay, so this is slightly different than the presenting part. Whenever we talk about fetal presentation versus presenting part, it can get a little confusing, okay? So whenever we talk about presenting part is the part of the fetal body felt first by the examining finger during the cervical exam. Okay, so when we're referring to this, we're trying to give a name to it. Okay, so instead of just saying, oh, fetal presentation, fetal head is down, right? In an exam, when we're talking presenting part, we usually say cephalic. Typically, occiput would refer to our cephalic presentation, where the baby's head is. Breech, we would describe as sacrum. Okay, those are the presenting parts. Fetal presentation would just be your overall arching, like head, butt, foot, you know. In a cephalic presentation, the presenting part is occiput, that is a vertex presentation. What I want you guys to know, what is the ideal presentation for delivery would be occiput, okay, which is a cephalic fetal presentation. Okay. So I want you guys to be familiar with the terminology whenever we're referring to fetal presentation, what this means, what terminology is used. If I say that there's a sacral presenting part, what does that mean? It means that baby's butt is coming first. Can we deliver vaginally in that instance? We should not. No. Okay, so please refer to these images, which have a lot of really good references for you as far as like your suture lines and your fontanelles. And then on the third image here, we can see fetal molding, the molding of that head as it's coming down through the birth canal. Okay. Continuing on our factors affecting labor with our passenger, which is our baby, right? Which, hint, hint, nudge, nudge, you guys are going to need to know the 5 P's that affect labor. Okay, passenger is one of them. Okay, fetal lie. All right, so here's that terminology that I was talking about. Fetal lie is referring to the relation of the fetal spine to the spine of the mom. Okay, the most common lie is longitudinal or vertical, which just means that baby is laying vertically, excuse me, vertically in utero, and their spine is lined up to mom. Okay. A transverse lie, which would be the third image down here that we see, where the baby is laying horizontally in utero, is not going to, they're not going to be able to deliver vaginally, right? Because even if we're having effective contractions, even if we're having strong contractions, that baby is in such a terrible position and that they would not be able to successfully deliver vaginally. So if you hear that somebody has a transverse lie, that typically means that that baby is going to need to be delivered via C-section. Okay. The way that we describe them would be longitudinal, virginal, transverse, horizontal, or oblique. Okay. But I want you guys to know that the most common and preferred would be longitudinal. Okay. Fetal attitude refers to the relation of fetal body parts to one another. So the most common with this um, is general flexion. Okay. So that's normally the back of the fetus is rounded so that the chin is flexed on the chest, the thighs are flexed on the abdomen, and the knees are flexed. The legs are flexed at the knees. The arms would be crossed over the thorax, and the umbilical cord lies between the arms and legs. Okay. Deviations from normal attitude may cause problems with the labor process. So your baby should be like pretty compact. We want baby to be curled in on themselves. That is referring to general flexion when we're talking about fetal attitude. Okay. If baby is extended in any way, that can lead to just disproportion of labor, interruptions of labor, uh, ineffective labor. So that is not what we want. We want general flexion whenever we're referring to fetal attitude. Fetal position is the relationship of a reference point on the presenting part, so your occiput or your sacrum, to the four quadrants of the mom's pelvis. Okay, this one is probably the hardest to understand. So I want you guys to review these pictures because I think that the images make it seem a little bit more understanding than just listening to me. Okay, so like I'll say it again. Fetal position refers to the relationship of a reference point on the presenting part, whether that's occiput, sacral, whatever, to four quadrants of the mom's pelvis. The first letter notes the location of the presenting part in the right or left side of mom's pelvis, so R or L. The middle letter stands for the presenting part of the fetus, which would be occiput, mentum, chin, sacral, whatever it may be. And then that last letter stands for location of the presenting part in relation to um, anterior, which is A, posterior, P, or transverse, T, portion of the maternal pelvis. Okay, so this is basically just telling us where that baby is inside of mom. Okay, so we see here that it's broken down into three letters. Like I have those examples there, ROA or LOA. Okay, so for example, ROA means that the baby's occiput, their head, is the presenting point and is located in the right anterior quadrant of the maternal pelvis. This is something that we want. That is a good fetal position. Okay. Um, so, like I said, please refer to the graph. There's other examples in your book. We're going to talk about this pretty extensively in class as well because I want you guys to understand this. But when we're talking about fetal position and assigning them those three letters, we're basically trying to determine where is baby in relation to mom's anatomy, to mom herself. Okay. Station is a little bit easier to understand. I have some good pictures on the next slide that we'll go through. This is the relationship of the presenting part to an imaginary line that's drawn between mom's ischial spines and is the measure of the degree of descent through the vaginal canal. So basically, this tells us how much further baby has to come down until they're delivered. Okay. So for example, when the lowest part of the presenting part is 1 centimeter above the ischial spines, pretend you got that horizontal line, that imaginary line. It's one part above, then the baby's station will be -1. If the presenting part is at the level of the spines, the station is 0. So if the presenting part is 1 centimeter below those ischial spines, then it would be +1. We know that baby or birth is imminent if we call this fetal station +4 or +5. Okay, so just think about it as baby is getting closer and closer to the vaginal opening to delivery, those numbers are going to go up. So you start negative and you work your way to positive. Okay, like I said, we're going to take a peek at this on the next slide and it'll make it a little bit easier to understand. Engagement is our last one that we want to talk about on this slide here. So if the fetal head is engaged, that means that it's well applied to the cervix and the head is present in the pelvic cavity. Okay. So is baby, like when you perform a cervical exam, are you able to hit that presenting part with your fingers? Do you have to reach really far up to feel the presenting part? Is the presenting part not even able to be palpated by a vaginal exam? All of that is going to be indicative of if that baby's head is engaged. Okay, and engagement just means that head is pushing down on that cervix, which is going to allow for labor to take place and for progression of labor to happen. Okay, typically baby's head is going to be engaged about the week before labor. This happens should happen before the mom goes into labor. It's usually what causes moms to go into labor. Okay, so let's look at this image on the next slide. This is going to refer to our station. Okay, so we have the ischial spines here. We've got that imaginary line. We have our fetal head. Baby's head is going to come down through mom's pelvis. If you can't even feel that baby's head, like there's no hope, that's a -5. Same with -4, -3. Typically, most people are unable to feel the baby's head until we get to like -2, -3 station. And then as baby comes down and descends, we're getting more to the positives. So once baby is in line with those ischial spines, we're at a 0 station, okay? +1 or +2, you're usually calling your provider because that mom is most likely complete and ready to deliver. +3, 4, and 5 is when she's pushing and baby is making the descent through the birth canal for imminent delivery, okay? So this is a really good reference image to understand fetal station. All right. So our second factor that affects labor is our passageway, right? Not only does baby need to be in a good position, their fetal lie needs to be good, um, the station needs to be appropriate, but we're now worried about mom's anatomy and the passageway itself, okay? So when we're talking about mom's anatomy, we need to discuss the bony pelvis. So what is all involved in this? We're talking about the pelvis, mom's cervix, her vagina itself, and then the soft tissues of the pelvic floor. Okay. Shape and size can be determined at initial prenatal visit to assess probable success of labor process. So whenever we're doing like that initial intake that we talked about a lot in week 1 and 2, part of our initial intake would be a pelvic exam to determine is this passageway conducive or beneficial or effective for labor? Okay. Do we think that labor or a vaginal delivery is going to be successful with this pregnancy? Um, so we're looking at the shape and size of the pelvis. We're looking at the favorability of that cervix, the vaginal opening itself, um, any like soft tissue of the pelvic floor. Does mom have pelvic floor dysfunction? Does she already have issues with this? If that's the case, then we need to start maybe like some therapy and talk to her about other options as well. We covered in week 1 the 4 different shapes of the pelvis, and I hope that you guys remember what the most common and most favorable pelvic shape for a successful vaginal delivery is, which is your gynecoid. So your gynecoid pelvis is the most favorable for a successful vaginal delivery. Okay. You do need to know that for sure. The other 3 are listed for you there, um, and each pose their own issue with delivery. Okay. So, when we're talking about soft tissues, during a vaginal exam, the cervix is felt to determine dilation and effacement. So, whenever a mom is laboring, we're in labor, we are going to be performing cervical exams to determine how far along and how progressed she is. Okay, we're going to talk about that in a little bit in another slide. So, we're going to be continually checking the cervix in labor as if it's appropriate to see how well labor is progressing. So our contractions will cause fetal presenting part to press down onto the cervix to cause changes in dilation and effacement. So that is the act of, with the contractions, that squeeze of the uterus, baby's head, if it's well engaged, is going to push down on the cervix and you're going to have it slowly start to thin and then it's going to start to open and dilate. Okay. We cannot have effective um, labor progression without effective contractions, right? If we're not getting a good squeeze and we're not pushing that baby down onto that cervix and that fetal head isn't pushing down onto the cervix at all, we're not going to be successful or have any change in dilation, okay? Effacement, like I said, effacement is that thinning of the cervix. And it's measured in percentage from 0 being that cervix is completely closed, thick, because the cervix is usually pretty long and thick, so it needs to thin out. So 0 would be thick, and then 100% would be that cervix is paper thin and you can barely even feel it, you barely even know it's there. Okay, and then your dilation, that's referring to the opening of that cervix. Okay, so effacement is the thinning of the cervix, dilation is the opening of the cervix, and it's measured in centimeters, so 0 to 10 centimeters. 0 being completely closed, 10 centimeters being that baby is ready to come out where you have no cervix left, the baby's head is what's in the vaginal canal, let's have a baby. Okay. Um, So, for example, if a woman comes to the hospital after an office vaginal exam and she is 6 centimeters, 80% effaced, and that baby is at zero station, what do we think this means? Let's think about what our cervical dilation and effacement uh, definitions are. 6 centimeters is over halfway dilated, right? If we're going from 0 to 10, 0 being closed, 10 being the cervix is completely gone or as open it's going to be and that baby is going to deliver, she's pretty progressed at this point. 80% effaced means that that cervix is already almost 100% thinned out. Okay. We need to have 100% effacement and 10 centimeters of dilation for infants to deliver correctly and safely. So, and that baby's at zero station. So that head is already in the ischial spines. That head is well engaged and coming down. So this lady is going to have a baby pretty soon. So it's kind of good that she was at a office visit. So we're going to be having a baby and we need to prepare her for that. This picture here, I love. I love these pictures. So we have on our left here the cervical dilation chart. This chart is going to be awesome to help visualize your guys' the cervical dilation within centimeters. So it shows you 1 centimeter to 10 centimeters of dilation and compares it to an orange slice, you've got cantaloupe melon, donut. So that's just really good to see kind of like how big that cervical opening will get during labor and how big it needs to get in order for the baby to safely deliver. That image on the right is an example of cervical effacement. So you can see on the left that that cervix is not effaced at all. It's very thick. You still have you still have the full cervix completely all the way thick, not thinned out at all. As baby's head starts to press down, that cervix starts to thin out, and then it will start to dilate, okay? You can't really have effective dilation without proper effacement, right? They go hand in hand. So I want you guys to be really familiar with what these look like and the differences between the two and how they are measured. So centimeters for dilation, percentage for effacement. Here's our third P for factors affecting labor, which is powers. Okay, so we have passenger, passageway, powers. So when we're talking about powers, we're going to split it up into primary and secondary. Primary would be your involuntary uterine contractions. Okay, like I mentioned before, contractions are responsible for the dilation, effacement, and fetal descent. Without appropriate contractions, we're not going to have any of those things. Certain external factors may change the effectiveness of this stage. So, if baby is in a terrible position where that head is not pressing down very well on the cervix, or if it's a butt, and butts are much softer than heads. And so, if a butt's pressing down on the cervix, it's not going to be as effective as if a hard head is pushing down on the cervix. If mom has previous history of cervical lacerations or any type of scarring, that can also sometimes impact how quickly she is going to be able to efface and dilate in labor. I know I mentioned last week a LEEP procedure. If a woman's had a LEEP procedure or any type of surgery on near her cervix or on her cervix, that can lead to difficulties in labor. And then the gravity of mom. So, like we talked about, right? We need to know our gravity and our parity. So, if mom is a gravity 1, which means this is her first pregnancy, right? She, her uterine contractions and the way and the effectiveness of her cervical dilation and effacement is going to be a lot slower, typically, than somebody whose gravity is 10. Okay. I say typically because not all cases are the same, right? We can't just assume that if a mom is a first time mom that she's going to have a long labor. We also can't assume that if a mom is having her 10th baby that she's just going to have the fastest labor ever because I've seen it reversed, okay? But sometimes that will affect it. Secondary powers refer to mom physically pushing. So, That is towards the end of labor. When we talk about the stages of labor, we'll get more in detail about that. But maternal labor, this refers to that strong urge and where they often cannot resist. That's your secondary powers when mom is pushing. So our primary would be our uterine contractions, secondary would be maternal pushing. Okay. We usually have to have a lot more contractions until it's time to push. So contractions will come first. That's why it's primary. Secondary would be mom pushing. Okay. Signs that can sometimes precede labor would be um, lightening, return of urinary frequency. If moms are experiencing a backache, that can sometimes lead to that. Stronger and more frequent Braxton Hicks contractions, a weight loss of 1 to 3.5 pounds. Sudden surges of energy can sometimes indicate that their mom is going to go into labor. Any increased vaginal discharge, cervical ripening. So, mom has made some cervical effacement or dilation or made some cervical change, and then possible rupture of membranes. So if mom's water breaks, that's going to show that she's almost ready to go into labor. Okay. So all of these things can be some signs preceding labor. Um, Stages of labor um, would be listed here for you guys. So labor is defined typically as the regular progression of uterine contractions. It means that mom has to have some progressive effacement as well as dilation, and then descent of the presenting part. Okay, all of these things need to happen for us to determine that mom is in labor. It is also covered in a lot more detail on chapter 16. Hold on one second. I'm going to move to a different room so that because my dog is currently resting. Give me one second. All right, thank you. So, like I said, labor is defined as these three things that we need to have in order for later labor to be considered progressing and effective. So we need to have progression of uterine contractions. So mom needs to be having frequent and regular contractions. Um, Also, we need to have progression of the effacement and dilation. So her cervix needs to be making change. And then we need to have continual progression and descent of the presenting part. Okay, so we need to be able to feel that baby is moving down into the vaginal canal. Okay, so all these things are important whenever we're determining whether or not labor is going to be effective. Um, so we're going to divide our labor into first, second, third, and fourth. So the first stage is the onset of regular contractions until full dilation. So whenever mom begins her labor up until she's fully complete, which means the cervix is completely gone, it's fully dilated, and we're fully effaced. Um, this is the longest stage, and it's divided into its own two separate like sub stages. So we have the latent, which is early, and the active stage. So during the latent stage of labor, there's usually more progress in effacement of the cervix and little increase in descent of the fetal presenting part. In the active phase, the descent and dilation happen more rapidly, and it's typically considered active whenever a woman reaches 6 centimeters of dilation. Okay, so that's how we would define that. Active labor is usually anything over 6 centimeters. Our second stage occurs whenever we reach full dilation and then until the baby is delivered. Third stage would be the birth of the infant until the delivery of the placenta. And then our fourth stage would be delivery of the placenta until after the recovery period when mom is considered, stable. Okay. So those are important things. I want you guys definitely to know the stages of labor. The mechanism of labor. Okay. Whenever we're talking about like how labor actively happens, right? What is baby doing? What is mom doing? What is the entire anatomy? How does the system work? What do we expect? What do we need for to happen for babies to deliver successfully? So first, we need engagement, right? We need that baby's head to be pushing down on the cervix. We need it to be pushing down so we can have proper effacement and adequate dilation. Okay. Um, we also need to take into consideration a definition called asynclitism, which happens when the head is poorly positioned for labor. So, and it's making a poor descent through the pelvis. So, asynclitism means that the head is poorly positioned for a poor descent through the pelvis. An example of this is if baby is in a position that we call occiput posterior, which means if you guys have heard the term sunny side up or OP. Uh, this kind of presentation is just when baby's head and maternal pelvis don't line up and vaginal canal don't line up as effectively. So we see long labor, irregular contraction patterns, and then an important term that you guys need to know is cephalopelvic disproportion. And that is just whenever the baby's head is not in a good spot in the pelvis and it's impeding descent. Okay, it's messing up our labor process. Descent refers to the progress of the presenting part through the pelvis, and it's determined by four factors. The pressure that's exerted by the amniotic fluid onto the baby, the direct pressure of contracting fundus on the fetus, so how well is that uterus squeezing and contracting, and then the force of contraction on maternal abdomen in the second stage of labor. Okay. Um, so these are all things that we need to take into consideration whenever we're talking about descent. So in this, the best way to measure fetal descent would be our station. How well is mom, how well is baby engaged in the pelvis? How far down is that presenting part? What is our descent? That is how we're going to be able to determine, is by if we know our station. Flexion is when we refer to flexion, the fetal head is typically flexed so that the chin is brought closer to that fetal chest, right? We already kind of talked about that when we were talking about passenger, how we want that baby to be kind of curled in like this. Okay, flexion would be the chin is brought close to the chest, and that's ideal for birth. We do not want to see that head up like that. Okay. Internal rotation, that happens naturally with contractions. That baby, as the uterus is pushing down on the baby, clamping down on baby, that baby's going to start to rotate and start to turn as they're coming down through the vaginal canal. And this is, they're just trying to get in an ideal position for delivery. Okay. Extension, this occurs when fetal head reaches perineum for birth. So this is just the natural progression of how baby is delivered. So first you have the occiput, which is towards the back of the head. Then you have the baby's face that's delivered. Then the chin is delivered. And then the expulsion, the baby's completely born. Okay, our shoulders have to be delivered obviously after our full head and face. But after that point, after that is the expulsion. Okay. So a good thing to do is honestly like look up a video of birth because you'll be able to see that baby come down occiput, face, chin, and you'll be able to see a little bit of that rotation and understand this mechanism of labor. Okay. What is our physiologic adaptation to labor? So what are some normal changes that we're going to anticipate for mom and for baby? Um, with baby, the fetal heart rate. So, what is our average fetal heart rate? It's 110 to 160 beats per minute. That is a normal fetal heart rate. Sometimes the heart rate is going to decrease as the infant grows closer to term. This is normal. This isn't something that needs to be concerning. In an early first or second trimester, babies' heart rates are anywhere from like 150s to 160s, and then they slowly, gradually decrease potentially during as pregnancy progresses. Circulation is going to change because circulation of the infant is impacted by uterine contractions and stresses of labor. And this is most commonly because of umbilical compression if they're having issues during labor. Okay, so circulation, as that uterus is contracting, as it's putting pressure on the infant, as it's putting pressure on that umbilical cord, that is going to be reducing infant blood supply, right? If the uterus is contracting, it's constricting those vessels, reducing the amount of blood flow to baby. So this can cause for fetal heart rate to drop. Okay. Umbilical cord compression is the most common that we see because of just where the anatomy is and how baby is laying, typically in utero. And if there's problems with labor, we see patterns in our in our fetal monitoring, which we're going to talk about later in this presentation. So, respiration. This is what I want you guys definitely to focus on. This is the biggest one that I want you guys to know. So, respiration, many changes can happen to prepare the infant for breathing once delivered. Okay, so your baby, while in labor, is already making the subtle changes to be able to transfer to where they're breathing oxygen or they're circulating oxygen. So, what happens? Okay, fetal lung fluid is cleared from air passages as the infant passes through the birth canal. Fetal O2 concentration is going to decrease. Arterial CO2 pressure will increase. Arterial pH will decrease. Bicarb level decreases, and fetal respiratory movements decrease during labor in general. Okay, so in labor, infants are typically in a hypoxic state. Not to the point where we're worried about metabolic acidosis, which is only going to happen if there's difficulties during labor or difficulties at birth. But babies do have a little bit of a depletion in respiratory effort during labor just because of the natural physiologic process and how they're going to be adapting to breathing oxygen. Okay. From a maternal standpoint, cardiac output is going to increase by 12 to 31% in the first stage of labor and even more in the second stage. Excuse me. Their heart rate is going to increase because they're in pain, just because of the overall way that labor is progressing. Blood pressure will typically increase during contractions as well because of pain. We'll see a white blood cell count increase. Respiratory rate will increase. Temp may also elevate during labor. Proteinuria may occur. Gastric motility and absorption of solid food are decreased. Nausea and vomiting in labor is very common. And then blood glucose levels will decrease as well. Occasionally, moms will hyperventilate during labor, so it's really, really, really important as their nurse that we're coaching them through labor. Okay, reducing the instances of hyperventilation because that can impact not only mom's respiratory status but fetal respiratory status as well. Okay. All right. Moving on to chapter 14, maximizing comfort for the laboring woman. So, pain during labor and birth. Many factors impact a woman's pain during labor and delivery. So, perception of pain. Pain is a subjective experience and is going to differ from patient to patient. It's important, obviously, as nurses, that we can listen to our patients and consider their individual circumstances whenever we're evaluating pain level. We are not here to pass judgment. We are here to support and help our patients, right? A 10 out of 10 for me could be a 2 out of 10 for the next person. You guys know this, okay? You know pain is the other vital sign. Expression of pain is going to be different because of lots of factors. Culture is a main thing that can sometimes affect expression of pain. You'll find some cultures will be overly expressive and want a lot of people in the room, and they're in a lot of pain right away or just are more expressive about it, whereas other cultures are a lot quieter with their pain management. So, like an example is I worked with the Amish patients a lot, and Amish are very stoic. They do not really show signs of pain very often. Even in labor, I had Amish women who would walk through the door and they'd be 8 centimeters dilated and they would just be sitting there as if nothing were happening. So we really need to listen to our patients and to what they are saying. Anxiety will also contribute to pain management to the level of pain that the patient is experiencing. So, if a woman has a high anxiety level and she's starting to let her breath and her breathing get away from her and she's hyperventilating almost, that is only going to increase her pain level. It's not going to help her manage it. So, we need to help coach that patient. A previous experience. If she had a terrible experience with her first delivery or another delivery, she's going to be a lot more anxious and anticipating a lot worse whenever she comes to deliver the baby that you're there helping her take care of. Okay. So we need to think about that too. Support. So we need to respect a woman's birth plan and preferences and be a resource rather than be a hindrance. Okay. Birth plan is something that we see a lot in labor and delivery. We see that with almost every patient now, that women will come with a written birth plan. So it is our job as a labor nurse that if it is possible to help her achieve her labor goals, that we help her achieve them. Okay. If she wants to have a tub delivery, as long as she has no underlying medical reasoning not to, let's help her get in a tub and have a tub delivery. If she wants 25 people in that room within reason, right, we need to let her have whoever her support system is in that room. Okay. And then environment. We need to be promoting a relaxing and environment that's conducive to a healthy and successful birth. So, moving on to pain management techniques. So, we will first talk about non pharmacologic pain management. Obviously, relaxing and breathing techniques are huge. Okay. Talking to your patient about breathing, deep breathing, and focusing on the breath during contractions. Counter pressure, that would just refer to if while someone is having a contraction, applying pressure on an alternative part of their body to try and distract them or uh, help with the pain. Touch and massage is very therapeutic. Application of heat and cold, acupressure and acupuncture. I'll preface this by saying I've never done or helped assist a woman with acupressure and acupuncture in labor. However, you always need to refer to your hospital policy and procedure. If your hospital does not actively offer acupressure and acupuncture in labor, then we cannot be promising our patients something that is not realistic. A TENS unit is helpful in labor. I have a picture on the bottom of the slide there of a woman who's using a TENS unit. It can help distract from pain. It can help lessen pain. Um, Hydrotherapy, getting in the water, getting in the shower, having a tub delivery, all of those things. Hydrotherapy is very effective and it's also becoming much more popular. Aromatherapy would refer to like essential oil use. Um, that is can be very calming and stress reducing for women. And oftentimes, if we reduce stress, if we reduce anxiety, we reduce pain. Music, hypnosis. Sometimes women will do what we call a hypnobirth. I don't know if you guys have seen any literature or anything about this, but hypnobirthing would just be like when mom's basically meditating during labor. Okay. Position changes. This is huge. We need to be able to help our moms into whatever position that they want to be in for their labor and for their delivery. So as long as baby and mom are safe, okay? Safety is always the number one importance. If it's not feasible and it's not safe, we should not be doing it. Um, but as the bedside nurse, get them up on the birthing ball, help them with the peanut ball, help them to get in the position that is going to make this less painful for them. And then that is kind of falls in line with the utilization of birthing tools. So our birthing ball, our peanut ball, our stool, our mirror, and then we can use resources such as spinning babies, labor and delivery nurse accounts. Sometimes we'll post like really cool positions that help with labor. All of these things are going to just make you a better bedside nurse and make you more valuable and helpful for your patient. So moving on now to pharmacologic pain management. Okay. So they're kind of broken up for you in categories. So sedatives, um, these are going to promote relaxation, but not necessarily provide pain relief. Okay. It's a great option early in labor or overnight for like a late induction start. Sometimes these can be given in combination with pain medication to enhance the effects of the pain medication and promote in general relaxation. But we have to be cautious because these meds can depress the central nervous system and may potentially cause respiratory depression. So, whenever we're giving these medications, especially if it's via IV, we need to apply a pulse oximeter and we need to have a reversal present at the bedside. Just use your nursing judgment with that too. Yes, we want to be monitoring O2 status if there's anything that can potentially cause respiratory depression. Okay, which goes for most of the anesthesia that you see listed here. Okay. Nitrous oxide, or aka laughing gas, is an inhaled anesthetic and it's administered in a 50-50 mix with oxygen using a blender device and it's held by the mom that's in labor herself. Okay. This does not completely remove pain, but it will increase the intensity. Some side effects of this include nausea and dizziness. So, as nurses, we need to make sure we keep mom in bed and administer an antiemetic prophylactically. When I talk about like how mom has to hold the mask, that means it's kind of like a PCA pump, right? Where sorry, my nose is really itchy right now. Where if you have a button and you're giving that to your mom is the only one that should be hitting that button for her pain management. Okay, so a family member shouldn't push that button. And that's the same with the nitrous oxide. Mom needs to be able to physically hold this mask herself. It is usually in part of policy and procedure in most hospitals. Okay. General anesthesia is not used in an uncomplicated delivery. If a general anesthetic is being used, we are delivering a baby emergently, okay, via C-section. So usually during a stat C-section, we're giving general anesthesia due to maternal or fetal distress. Okay, what happens is mom is going to be completely put under, and usually there's like a tube down her throat. She's not breathing on her own, and this baby needs to be delivered immediately because general anesthetics can have an effect on the fetus. So we're typically taking that mom back to the C-section. We're putting her on the table. Everything is draped. Everybody is ready. We are all ready and set to go. Anesthesia says, okay, go when the mom is put under, and we have that baby out within a minute. Okay. Generals, I just want you to know, are not used for a regular standard delivery. Nerve block, analgesia, and anesthesia. So a local is typically used after delivery for perineal repair. That's typically lidocaine. Okay, so a local anesthetic would just be like administered into the soft tissue or the muscle for a perineal repair. A pudendal block may be administered late in the second stage of labor. So this is just a deeper base of pain management coverage without necessarily doing an epidural or a spinal. So this is typically if mom is going to be getting an episiotomy where they're cutting her perineum in order to make room for the baby, that kind of a block is more effective because it covers deeper into the musculature, which is where the physician will be cutting. Okay. Spinal is an anesthetic solution containing a local anesthetic alone or a combination with an opioid agonist. It's injected through the third, fourth, or fifth lumbar space into the subarachnoid space. Spinals may be used for vaginal birth, but it is not suitable for labor. So sometimes if a provider is doing an epidural, they can dose it with a spinal dose, which is just a little bit of a heavier medication, but that is not going to be given like continuously, and it's also not really what we recommend to give during labor. Typically, spinals are for C-sections. They're a little bit longer acting. Okay. An epidural is the gold choice, most common choice during labor. This happens whenever bupivacaine is injected into the epidural space, and this form of medication administration results in the least amount of central nervous system depression, and it reduces the risk of fetal respiratory distress and other complications. Okay. With an epidural, though, we need to think about it. So, epidurals are typically continuous infusions. They're usually set up on a pump, And they can be given as a PCA or they can just be set with a continuous mLs per hour rate. It just depends on your anesthesiologist. As nurses, we are not allowed to change the rate of an epidural. We can change out the epidural bag if it runs out. We can change the batteries on the epidural machine. We can change the tubing, but we are not allowed to change the settings, and we are not allowed to restart it without your anesthesia provider there unless it had already been started for you. With epidurals, the important thing to know is the biggest side effect of an epidural for mom is hypotension. So we're really worried that mom's blood pressure is going to drop during an epidural. Okay, so with epidurals, we're usually having mom sit on the side of the bed facing the nurse. The anesthesia provider is behind them, inserting the epidural. We have them monitor their blood pressure probably every 2 minutes during the actual procedure. And then afterwards, we're measuring it and analyzing it for about 15 minutes until baby is born. Okay. If mom has a hypotensive episode where she vagals, she passes out, what would we do? We're going to lay her right down on her side. We're not going to keep her sitting on the side of the bed. We're going to bolus in her fluid. We're going to raise her feet without lowering the head of her bed because remember, she just got an epidural, so we don't want that epidural to rise up to her chest or above because that can cause respiratory depression. But we're going to lay her flat. We're going to run in an IV fluid bolus, and we're also going to administer ephedrine. But typically, anesthesia is who's going to administer that for you. Okay, so some interventions for hypotension with epidural management might be something that you guys will definitely want to review. Okay. What is our responsibility for pain management interventions? We need to get consent. We need to make sure a patient is okay, especially with an epidural. If the anesthesia provider is getting consent, we need to witness that consent and be aware that mom is okay with receiving the pain management. We need to have an order. So we're not just going to let the mom get an epidural whenever she wants one. We need to make sure that the physician that's ordering it is okay with her having it. We're documenting whatever that looks like at your facility. Scanning meds in order to reduce med error. Having a reversal agent ready if appropriate. Assisting with positioning. So like for an epidural, having her sitting on the side of the bed, leaning over, monitoring the baby, monitoring her blood pressure, monitoring mom's vital signs. All of that is going to be extremely important. Whenever we're administering any type of medication, any type of pain medicine, we need to continually monitor our infant. Typically, we're also monitoring mom, but monitoring baby is huge. So if we're giving her any kind of pain management, you best believe that baby better be on the monitor. Obviously, follow your hospital policy. Ensure that patient safety is priority number one. Okay? Fetal assessment during labor. So this is where we're jumping in to talk about contraction monitoring, fetal heart rate monitoring, and reading fetal heart rate tracings and reading strips. We're going to talk about this and do a lot of practice as well during class. Okay. First off, why are we monitoring? So for babies, labor is a period of high stress for the baby. Okay. Our fetal response, fetal oxygen supply can decrease for a number of reasons. There's reduced blood flow due to maternal hypertension, reduced oxygen content in maternal blood because they're having a hemorrhage or severe anemia. Alterations in fetal circulation can occur because of compression of the umbilical cord or other abnormalities. And then reduced blood flow to the placenta because of uterine hypertonia. Whenever you see hypertonia, that means too many contractions. Hypertonic, we're having too many contractions, which is reducing the fetal oxygenation. Okay, we need to know our normal heart rate and baselines. So in order to be successful, reading fetal heart rate tracings and reading contractions tracings, we need to know what the normals are and what our parameters are. Okay, so like we said, there are many physiologic changes that occur in labor. Uterine activity. Okay, Um, we need to know our normals, okay? How often should a mom be having contractions? How many contractions are too many contractions? How many are too few contractions? Obviously, none. If you're not having any contractions, you're not going to have a labor, right? And then fetal compromise. So, abnormal fetal heart rate patterns are associated with fetal hypoxemia, right? Which we talked about when we talked about the physiology of labor, and we said that baby can be in a hypoxic state during labor, um, and that's usually because of a deficiency of oxygen in the blood. If uncorrected, this hypoxemia can deteriorate to severe fetal hypoxia, which is an inadequate supply of oxygen at the cellular level, which then we're starting to talk about metabolic acidosis, right? Metabolic acidosis is the worst that a baby could be in. We do not want babies to be in metabolic acidosis. Metabolic acidosis, in turn, can lead to acidemia or an increased amount of hydrogen ion content in the blood. This is going to result in tissue dysfunction, cellular dysfunction, and sometimes even fetal demise. Okay, so basically, the purpose of saying that is baby will progress very quickly if we do not oxygenate the fetus and we do not make that our number one priority. Okay, we're trying to avoid metabolic acidosis because metabolic acidosis can result in tissue dysfunction or even fetal death. Okay. When we're monitoring a baby, we can monitor them intermittent or we can monitor them continuously. Intermittent monitoring is reserved specifically for only healthy, non complicated pregnancies and fetuses that are doing well in labor. Okay. And to be honest with you, it's rare to intermittent monitor anymore. Most women are getting continuous monitoring. So, as the nurse, we need to be able to communicate with our provider to see is intermittent monitoring appropriate. If a woman comes in and is refusing monitoring, we need to have her sign a basically an AMA form saying that the hospital will not be liable if she's refusing this monitoring and what could happen as a result. Okay. All right, so before we start reading tracings, we need to know what our normals are. Okay, let's talk about this vocabulary because the vocabulary when we talk about labor is sometimes the hardest thing for people to understand. So I want you guys to understand it really well. So there's some important language that you need to learn before we analyze strips. So our baseline fetal heart rate is something that we are going to look at whenever we're analyzing fetal heart rate tracings. So the average rate during a 10-minute segment is what our baseline fetal heart rate would be. And that is excluding periodic or episodic changes. So basically, where is your baby's heart rate consistently during a 10-minute segment of tracing? There must be 2 minutes of interpretable baseline data to determine fetal heart rate. So if your baby's heart rate is hard to tell what the baseline is, you need to make sure that you can get a good read on it before you're doing anything invasive. Okay. Then we need to know our normals and what is tachycardic and what is bradycardic. So we know our fetal heart rate baseline should be somewhere between 110 and 160 because that's a normal fetal heart rate, right? We want our baseline to stay within normal. So what would be tachycardic? A fetal heart rate over 160 beats per minute. What will cause fetal tachycardia? Some things like maternal fever or infection, medication administration like terbutaline, maternal hyperthyroidism, fetal anemia, caffeine and cocaine use can cause fetal tachycardia. Those are the biggest ones, okay? On the other side, we're talking about bradycardia. What is bradycardia? A fetal heart rate that's under 110. What will cause it? Heart blocks, any type of structural defect, viral infections, maternal hypoglycemia, maternal hypothermia, and then disruption of oxygen to the fetus. Okay? When we talk about variability, when we're talking about our fetal heart rate and looking at our fetal heart rate on a tracing, this is described as waves or fluctuations in the fetal heart rate baseline. It is a characteristic of a baseline heart rate. There are 4 different categories: absent, minimal, moderate, and marked, which I'm going to show you guys pictures of these, okay? So variability basically just means how much differentiation do you see in that baseline, in that fetal heart rate, okay? How much is it going up? How much are we having accelerations? How does it look, okay? Absent is not good. We're probably having a C-section. Minimal just means that there's only slight deviations in the baseline, not super active. Moderate is usually what we want. That's our gold standard, what the normal would be. And then marked is just there's a lot of deviations from the baseline to the point where we can't even tell what baseline is because there's so many changes. Accelerations are visually apparent abrupt increases in the fetal heart rate, baseline rate. The peak is 15 beats per minute above the baseline, and the acceleration lasts for about 15 seconds or more. So for it to be an acceleration, it needs to go up by 15 beats per minute, and it needs to last for 15 seconds or longer. So 15 by 15. Decelerations. So this is the part of the fetal heart rate that you guys are going to have to identify on an exam. So you'll see a decel, and I'll be like, what causes this? What are our interventions? What do we do about this deceleration? So decelerations may be benign, so some are okay and we expect to see them, or some are abnormal and they need interventions. There are categorized as earlys, lates, variables, or prolonged. Okay, so let's take a look at all of this stuff. So we have here fetal tachycardia because we can see up here is our fetal tracing. This line up here is our fetal heart rate tracing. The line on the bottom with the waves, that is our contraction pattern. And you can see that the strip is divided into minutes. So these bold line to bold line is 60 seconds. Each individual little box here is 10 seconds. Okay. So our baseline here is 180. You can see that because it's written on the numbers here are written on the side for you to see. Bradycardia would be over here, right? Sorry, I can't see my screen super well. Yeah, because our baseline on that strip is about 90. Okay, so that's just telling whether or not our heart rate is high or our heart rate is low. Okay, or if it's normal. Here are some really good pictures of variability. So when I was talking about absent variability, that is this one on the top left here, where we don't have any activity going on in that baseline. It's a flat line, okay? That is bad. We do not want to see that, okay? Minimal variability is here, where we still have a little bit of movement, okay? We're not super concerned. Babies can have periods where they have minimal variability, and that's okay. You know, they have rest cycles. We just get nervous if it lasts for a long time. Moderate variability you would see right here where there is some deviation in the baseline, some changes in the baseline, and that's good. Marked variability are these really, really drastic changes in that fetal heart rate where it's hard for us even to tell, like, what is our baseline here, right? So whenever you're reading fetal heart rate, the first thing I want you guys to start with is, what is my baseline, right? Kind of like with analyzing a human, not human, an adult EKG. If we're analyzing strips, right, what is our rhythm? We want to know that immediately. Can we find a rhythm? What is our baseline? So right here in fetal heart rate tracing, I want you guys to think, when you're looking at strips, what is my fetal heart rate baseline? That's going to make everything else a lot easier. Okay. So when we're talking about accelerations, so let's look at this picture here. According to this strip, it looks like our baseline is 150 because that's where the heart rate is at is most consistent. Okay, the heart rate is at 150 most often. Accelerations are these little peaks that we see in the heart rate that go up by 15 beats and last longer than 15 seconds. Okay, so those would be examples of accelerations. I think we're going to be moving into our decels here next. Yep, so we're talking about decels here. So the first one we're going to talk about is early deceleration. These are visually apparent gradual decreases in and return to baseline of the fetal heart rate that is associated with contractions. So earlies, they go down at the same time that a contraction comes up. They mirror each other. Okay? If you hear that on the exam or on a quiz, what deceleration will mirror a contraction? That'd be an early decel, okay? This is caused by fetal head compression and it is a normal and benign finding. If we see an early deceleration, we're not going to be concerned, okay? That's just normal head compression. The baby's getting squeezed a little bit, but we're not worried about it, okay? Because it's happening at the same time as a contraction. The onset, which is your nadir, which is the lowest point in the contraction, okay? Think about it as the lowest point here. And recovery, it corresponds to the beginning, peak, and end of the contraction. Okay, so like I said, they mirror each other almost directly. And this is not something we're going to be doing interventions for because it's benign and we're not worried about it. On the other hand, we have late decelerations. These are decelerations that begin after the start of a uterine contraction, and the nadir or lowest point of the deceleration occurs after the peak of the contraction. So the fetal heart rate is running late. That's how I think about it. So you have your contraction happens, and then boom, your heart rate drops after. So your fetal heart rate is running late. If you see this, this is an emergency. Late decelerations are not good, and we do not want to see them. Whenever the nadir is after the point of the contraction, when it happens after. The decel does not normally return to baseline after the contraction has ended, and it's caused by a disruption in fetal oxygenation, so we need to use interventions. What are our interventions during labor? Turning our mom on her left side, giving her an IV fluid bolus, sometimes putting her in hands and knees to reduce any compression that might be happening on the umbilical cord. Administering oxygen via non-rebreather face mask. Those are our interventions, and those we would need to be doing for a late decel. We would also need to call our provider, okay? Because these are emergent. Variable decelerations is an abrupt decrease in the fetal heart rate below baseline. The decrease is at least 15 beats per minute or below the baseline and lasts at least 15 seconds and then returns to baseline in less than 2 minutes from the time of onset. So they're just these really deep and sharp, they look like V's. That's how I remember variables. Variables look like V's. They're very sharp, sudden drops, okay? They're caused by cord compression and can happen with or without uterine contractions. We can have a variable randomly, and that's okay. Babies will do that sometimes. They can occasionally be clinically insignificant, which means that sometimes they're benign and we don't have to worry about them. But if they're happening recurrently with every single contraction, or they're happening all the time without anything going on with your labor, that's typically something that we'd be concerned about, okay? And we would need to do some interventions. Okay, so think variables, V. Now, prolonged deceleration. Oh, I just hate looking at that picture. That gives me anxiety. This is a decrease in the fetal heart rate of at least 15 beats per minute below fetal heart rate baseline, and they last more than 2 minutes, but hopefully less than 10 minutes. Okay. It occurs whenever there are mechanisms responsible for late or variable decelerations last for an extended period. So if you're having lates and you're having variables for a long time, ultimately you're going to have a prolonged deceleration because that baby's going to poop out on you, okay? And it's because of a prolonged disruption in fetal oxygenation. Emergency. These are emergencies. If you see that, you're preparing to go back for a C-section most of the time. So we need to intervene. We need to turn our mom on her left side to increase the perfusion of blood flow to the placenta, give her an IV fluid bolus, administer oxygen if it's 10 liters via non-rebreather face mask, put her on her hands and knees if we still don't have that fetal heart rate recover back up to that original baseline, and call our provider because we're going to most likely have a C-section. We talked a lot about fetal oxygenation and how it's disrupted during labor, but I want to get more specific. What causes disruption of oxygen transfer itself from mom to baby? Uterine tachycystole. When you see that, that means mom is having too many contractions too close together. If we have continual contraction and we have that squeeze on that baby and it does not let up long enough for baby to recover, for that circulation to resume, and for oxygenation to take place, baby is going to start having decelerations, and not the ones that we don't mind. Like, we're talking like variable, recurrent variables, late decelerations, prolongs. If mom's blood pressure drops during an epidural, anything that happens to mom is going to happen to baby. So if mom's blood pressure drops, oftentimes we see a drop in the fetal heart rate. Um, Epidural or spinal anesthesia always runs the risk of interrupting oxygenation to the baby. If there's a placenta previa or some type of alteration in the placenta that's abnormal, that can disrupt oxygen transfer. If our placenta is abrupting, where it's separating off of the uterine, off the wall, and it's coming early, and obviously the placenta is what we're relying on for fetal oxygenation, then that is going to disrupt oxygen transfer. Hypertension, we talked about that in weeks 1 and 2. That constriction of the blood vessels will reduce the amount of blood flow to the placenta, leading to fetal intolerance. If a mom is post term, why do you guys think post term gestation? Think about it. So, your placenta kind of has like a shelf life, I guess you would say. Best used by enter woman's due date. Okay? So for me, my placenta, best used by May 11th to 2026. The later you go off of that due date, the less and less your placenta is perfusing as effectively. It does not mean that the placenta is immediately going to stop working after the due date. That is not realistic. But what I'm talking about is the vessels and the overall anatomy and structure of the placenta begins to break down. It begins to start working less. And so whenever you have like a post-dates induction, oftentimes you'll see baby show signs of a tired placenta because that placenta is not perfusing as well the later into gestation that you go. Okay, so if I have a 42-week mom coming in for an induction of labor, I'm going to see that and I'm going to think she's probably going to need a lot of fluid during labor to just increase the circulation and perfusion of blood down to the placenta because my baby is going to have minimal variability. Okay, that's usually what you see with a post-dates induction. That baby just is not as active or not as having as many has much variability as a baby who's in a placenta that's 38 weeks, you know. Um, Fetal growth restriction will reduce the amount of oxygen transfer. Diabetes is going to reduce the amount of oxygen transfer. And then any type of amniotic infection. If that amniotic fluid or intraamniotic is infected, then we're most likely going to see a disruption of oxygen as well. All right, so we kind of talked about this already, but nursing interventions for late reoccurring variable and prolonged decels. We're going to call our doctor, okay? Not necessarily first, but that is definitely high up on the list. If we are running in any medication to cause mom to have contractions, which is oxytocin, which we will talk about in a bit, we need to shut that off. Before you do any other intervention, if you are having Pitocin running through your IV, you need to stop it, okay? Turn mom onto a left side lying position. Administer oxygen at 10 liters per minute via non-rebreather. Correct maternal hypotension by elevating legs, doing all those interventions I talked about when we were putting in an epidural. Give her a fluid bolus. We're going to feel her belly to make sure that she is having a resting tone. If her belly is continuously firm, that could be a sign that she's abrupting, and that would be even a bigger emergency. Call our doc. Consider internal fetal monitoring, so like a fetal scalp electrode, IUPCs, intrauterine pressure catheter, those devices that we can use to help measure fetal heart rate. And then assist with preparation for birth if decelerations cannot be corrected, and that's a C-section. Okay. If you're going to screenshot anything or save anything or look over anything, study anything, this is an awesome mnemonic. You guys may have heard of it already during your clinicals. Veal, chop, and mine. Basically, it lines what our fetal heart rate pattern is. So what kind of decel are we experiencing? What is the cause of this deceleration? And what is the management? Okay. So, a variable deceleration, what causes it? Umbilical cord compression. What is our management? We're going to reposition mom, maternal repositioning. Early deceleration is caused by head compression, and we are going to identify the labor progress. See how mom is progressing in labor. Usually, if there's head compression, baby is progressing down through the vaginal canal. Accelerations, those are okay. We're not going to intervene. Late decelerations is usually because of placental insufficiency, which means that baby is not getting enough oxygen, and we're going to do our interventions. Okay, so please, please, please study this. This is going to help you a lot for your exam and for identifying types and causes of decelerations. Okay. So we need to know our normals whenever we talk about contractions. So we already went over fetal heart rate. We talked about the abnormalities in fetal heart rate. We talked about our terminology, what we need to know whenever we're discussing fetal heart rate. But there's some important language that you need to know whenever we're talking about uterine contractions as well, right? So whenever we're talking about contractions, the main categories of which we are defining them is, intensity, duration, frequency, and resting tone. So our intensity, we are describing that as mild, moderate, or strong. This is whenever nurses or providers will feel a mom's belly as she's actively having a contraction to assess for how strong that contraction is. Okay, so mild would be if you feel your nose. That would be what a woman's belly is going to feel like during a mild contraction. Moderate would be your chin. Strong is your forehead. Okay. So this is palpated at bedside using, or it can be assessed using an intrauterine pressure catheter. And like I said, the nose or chin or forehead. Duration is measured in seconds, how long your contractions are lasting. Okay. And it's measured from the beginning to the end of a contraction. Frequency is measured in minutes, and that's how often are these contractions occurring. How often are we having contractions? Every 1 to 2 minutes, every 3 to 4 minutes, every 5 to 7 minutes, whatever it may be. This is measurement of the beginning of one contraction to the beginning of the next contraction. Okay, contraction to contraction. Resting tone. So that is the measurement of the tone of belly in between contractions. We want that tone to be soft. We do not want to feel that mom's belly in between contractions and it to still be rock hard. Like I said, that can indicate that the mom is abrupting, and that would not be good. So this is palpation as well. So some of the stuff for uterine contractions we need to do at the bedside with our patient. Here's a really good picture that shows you all the things. So when we're talking about duration, you can see here, we measure from the start of one contraction to the end of one contraction. Frequency would be the start of one contraction to the end, to the start of the next contraction. Okay. Intensity, like I said, you can feel it and palpate it and list it as mild, moderate, or strong. The only time you'd actually get a measurement for intensity is if you're using an intrauterine pressure catheter to measure it itself. Okay. So let's know our normals. Okay, when we're gonna put it all together now. Okay, so what is our normal fetal heart rate? 110 to 160. What do we want our baseline variability to be for our fetal heart rate? We want it to be moderate. Moderate variability is the best. Do we want to see any late or variable decelerations? No. Early decelerations can either be present or absent because we don't really care if we're having earlies, those are okay. And then accelerations can either be present or absent. Those are defining characteristics for category 1 fetal heart rate tracing. If you guys want to look at what all the different categories of fetal heart rate tracings are, be my guest. They're on page 357. You can go through categories 1 through 3. But I want you guys to know what the normal is and what our standard is, okay? What is our standard for uterine activity for our contractions? So our frequency should be, a mom should be having 2 to 5 contractions every 10 minutes. Okay. Anything more than that, a contraction every minute, that's too many. That's too many at once. That's tachysystole. And then obviously, if you're not having contractions, you're not making progress. The duration, the contraction should last from 45 to 80 seconds, and they don't usually exceed 90 seconds, but I've had contractions last 2 minutes before. It just depends. But for effective contractions, they should be between 45 to 80 seconds. Strength. So they should be palpable. If you're using an IUPC, that's the measurement. You guys don't really need to know that. Resting tone, your belly should be soft in between your contractions, okay? Relaxation time should be at least 60 seconds or more. So you should have at least 1, if not 2 minutes in between each contraction so baby can properly reoxygenate, okay? Let's practice. Use this link. I know I sent you guys the copy of this PowerPoint. Please, please, please use this link and practice. There's some really awesome strips on there. It'll like mimic fetal heart rate tracing, okay? Types of monitoring. So we have external monitoring. That's whenever you have the ultrasound and then the TOCO or the transducer, which is ultrasound here, TOCO or the contraction monitor up here. The ultrasound transducer monitors your fetal heart rate, where the TOCO transducer is going to monitor uterine contractions. So this one down here is giving us our fetal heart rate and our fetal heart rate baseline. This one up here is showing us those contractions that we see on our fetal heart rate tracing. Internal monitors. Okay, so we have what's called a fetal spiral electrode, which is a little metal needle that screws in to fetal scalp during labor. Nurses are allowed to place these. Okay. Important thing whenever we're talking about fetal scalp electrode, this gives you a more accurate fetal heart rate, especially for women that are hard to trace, or if a baby has a long deceleration and we need to monitor them more closely, we would use these. Okay. Whenever you're placing it, it's important that you get that placed on the bone and not in a fontanelle or on a suture line, because that can cause some damage. Intrauterine pressure catheter, doctors have to place these. Providers must place these. These more accurately measure the strength of contractions via Montevideo units. Okay, so on that previous slide, let me go back to it really quick here. When we're talking about strength, Montevideo units is what we use whenever we're monitoring contraction intensity. Okay, with that IUPC in, we're able to actually measure how strong a contraction is on a numerical scale. Without an IUPC, we're just feeling the intensity based on palpation and giving it a mild, moderate, or strong. Okay. This is also used for amnio infusions. So an amnio infusion is if like mom's water broke really early in her labor and baby is showing signs of distress. Sometimes administering fluid or inserting fluid into that amniotic space to cushion the baby and provide a protection from the contraction will help reduce the instances of fetal decelerations. Okay, so these are our types of monitoring. Obviously, our most common is the external with the ultrasound and the TOCO transducer. Some other methods of assessment intervention. So fetal scalp stim, this is just referring to if a provider does a vaginal exam and gently rubs the fetal scalp to assess for presence of accelerations on the fetal heart monitor. So is your baby reacting whenever you're touching the head? Are they having accelerations or not? We need to know that. But like it's listed here, it's not as common, or it's sometimes medically not advised. Umbilical cord acid-base determination. This means like if your baby shows signs of distress during labor, sometimes providers are going to want to collect what we call cord gases. This is going to analyze if baby is in a metabolic acidotic state or not. Okay. And this is just done by either provider or nurse. We get the samples of the cord blood. After delivery, we get an arterial and a venous gas. We send it to the lab. They give us the pH values, all that stuff, and we interpret it, okay, to determine if our baby was acidotic or not. Some hospitals do that for every patient. I have not worked at a hospital that does them for every patient, but I know bigger hospitals typically will do cord gases, and it's sometimes something too that providers prefer to have as a cover your bases type thing. Okay, we briefly talked about amnio infusion. This is an infusion of a room temperature isotonic fluid, typically LR or normal saline, into the uterine cavity if amniotic fluid is low. Okay. Adding additional fluid may relieve umbilical cord compression if the fetus is showing signs of distress or fetal hypoxia. Tocolytic therapy would be administering drugs that inhibit uterine contractions. So terbutaline is the main one. One thing that you need to know about terbutaline is that it can cause fetal tachycardia. Okay, so terbutaline is a anti-tocolytic drug, or tocolytic drug that will reduce the instances of contractions. All right, let's take care of our mom during labor, especially during the stages. We're going to learn here. All right, so during the first stage of labor, this is like we talked about. The first stage of labor begins with the onset of regular contractions and it ends with complete cervical effacement and dilation. We have that latent phase, we have that active phase. The latent phase is the onset of labor characterized by regular painful uterine contractions that can cause cervical change. And then it lasts until the beginning of the active phase of labor when cervical dilation occurs more rapidly. We said that our active phase of labor typically begins at 6 centimeters dilation and ends with complete cervical dilation at 10 centimeters. Okay, I love these little pictures that are on here. So please refer to that whenever you're studying the material too. Okay. What do we do as nurses if a mom is in her first stage of labor? We're going to interview the patient. She's usually coming to the OB unit at this stage of labor. So we're going to interview the patient. We're going to triage her. If mom says that her water broke, we're going to get a couple tests. So a nitrazine paper or a Fern test. That's when the provider will look and get a swab of the vaginal fluid and look under a microscope at it. And ferning would mean that there is presence of amniotic fluid. An amnisure or an actin prom is also a swab of the vaginal canal that can test for presence of amniotic fluid in the vagina, which would be a positive, and that means that the mom's water has indeed broke. Okay. We're going to perform a cervical check if it's appropriate. We don't typically perform cervical checks on moms that are anywhere earlier than 35 weeks. If you have a mom that comes in early, I would ask your provider before performing a vaginal exam. You also aren't going to perform a vaginal exam on a patient who has a history of a placenta previa, right? Because you run the risk of rupturing. We're going to review mom's birth plan with her, talk about what she's expecting or wanting from her labor experience, put the patient on the monitor to assess for fetal well-being, review the prenatal and medical history, make sure there's no underlying comorbidities or things that we need to be aware of for delivery of the infant. We're going to assess her vitals, especially her pain level. If she's able to tolerate vaginal exams and she's able to breathe through her contractions still, maybe potentially even talk through her contractions, that'll make this interviewing and triage process a lot easier than a mom comes in ready to have her baby or ready to get an epidural. We're going to get a urine sample if indicated for high blood pressure. Check for bloody show or leaking of fluid. Bloody show can be an indicator that labor has started or that mom is experiencing labor. And we want to make sure that she's not bleeding. And by bleeding, I mean like filling a pad an hour. Okay. If it's just a little bit of blood on a pad or a panty liner that she's had on for a while, that could just be cervical change because she's in labor. But if she's bleeding profusely or bleeding through pads, then we need to call the provider and have somebody come in and evaluate this patient. If we decide to admit this patient, we're going to then need to insert the IV and draw labs. move the patient to an actual delivery room, not just her triaging room. We're going to use non-pharmacologic or pharmacologic pain management interventions to help make her more comfortable if that's what is in part of her birth plan. Make sure this mom is still drinking a lot of fluid. Help her with elimination, support her in labor, positioning, educate her and the support person on what they can expect and help with. And then we're going to prepare our room for delivery and anticipate any complications and other necessary equipment that we may need. The second stage of labor. This is the stage when the baby is born. It begins with full dilation and complete effacement, and it ends with the birth of the baby. So we also can break the second stage down into two phases, the latent and the active pushing phase. So laboring down, that just means it's a period of rest and calm, um, where the baby is just passively kind of descending through the vaginal canal. The mom is probably complete. She's definitely complete because that means she's in the second stage of labor, but she's not having that urge to push yet. That's just the baby getting into a better position for starting a push. Okay. And then we have the active pushing phase. This is when that Ferguson reflex is activated, or the fetal ejection reflex. That is the mom's like really, really strong, intense, I'm gonna poop, I need to push urge. Okay. And most of the time, you can't tell a mom not to if she is wanting to. Okay, so that is what we're looking for here, that strong, strong urge to push. What do we do in the second stage of labor? We're obviously going to check her. We're going to make sure that that cervix is completely gone. If her cervix is not completely gone, she's not ready to push. If we push on a cervix, we run the risk of having a cervical tear or a cervical laceration, which is extremely dangerous and can cause a lot of bleeding. Okay. If we check her, we're like, yep, yeah, girl, let's do it. It's time to have your baby. No cervix is left. That baby's head's right there. We're ready to go. We need to call our doctor. Okay, we're not delivering that baby unless, I've delivered probably 10 or 11 of them, but not by choice, just because it was happening too quick and we couldn't stop it and the doctor wasn't there. But we want our doctor to be aware. We also want to continue to monitor our baby, continue to monitor our infant. We're going to get our warmer ready. We're going to have all of our other medical personnel in the room that we need. Um, assist mom with breathing techniques and position changes. We can still be doing all of that coaching during the second stage and pushing. And then also, obviously, too, we're going to help coach the mom how to push during labor, especially first time moms that have never done it before. You've never pushed, you don't know what it's supposed to feel like or what you're supposed to do. The third stage of labor, excuse me, that lasts from birth of the baby until the delivery of the placenta. Nursing interventions during this stage. We're going to assist the mom to push for the placenta. When that placenta detaches from the wall, mom will feel like she has to push again, kind of. So we help her deliver the afterbirth, deliver that placenta. We're going to help the provider collect cord blood and cord gases, provide pain relief, perform perineal care, assist the baby into skin to skin contact, provide time for parents to bond with the infant independently. We're going to encourage breastfeeding if that's indicated and that's what the mom wants to do and it's on her birth plan. And then we're going to advocate for delayed cord clamping if possible. So 30 to 60 seconds after the infant is delivered, then we can cut the cord, or until the cord is done pulsing or is white in color. Okay. The fourth stage of labor begins with the expulsion of the placenta and lasts until the mom is stable in the immediate postpartum period. Our assessment and our interventions in this fourth stage. So this is like just typical care, your standard of care after a mom has delivered her baby. What are we going to do? We're going to assess blood pressures every 15 minutes for the first 2 hours. We're going to assess her pulse continuously during this period, assist with perineal repair, help empty her bladder. If you have a full bladder, so you have that full bladder and it's pushing up on the uterus, that uterus is not going to be able to fully clamp down. Okay. So it's going to cause more bleeding. If your uterus is soft and it's not fully firm, you're going to have some bleeding, okay? So make sure that her bladder is nice and empty. That's just good nursing care that prevents her risk for hemorrhaging, okay? We want to observe her lochia, which is bleeding. We want to know the amount, the location, and the color, okay? And then fundal assessment and massage. So we'll talk about that a lot more next week whenever we're talking about like what a fundal massage should feel like. But typically, your fundus should be firm, which is your uterus after delivery. It should be firm, midline. Usually it's right at the belly button line, maybe a little bit above, maybe a little bit below. We'll talk about that as well more in later in this class. But when we talk tone, just like is it hard, firm, soft, whatever. And then so we're doing our fundal checks and we're making sure mom's bleeding stays under control. Okay. So for our nursing assessment here, I have this mnemonic over to the side, bubble. We're going to assess her breasts for any tenderness, her uterus for her tone, make sure that there's no bleeding. Does she need to pee or poop? What is her bleeding, her lochia, which is what we call bleeding in OB, lochia from your perineum. And then episiotomy. Does she have a laceration? How does it look? Is it getting infected? Is it healing properly? And then any lower extremity issues like DVTs. Has she been bedbound for a while? Like, what was her labor like, you know? And then emotionally, how is the mom doing? How is she bonding with her newborn baby? Okay, so when we're performing a fundal exam, okay, like we just talked about, when we're assessing uterus and her uterine tone, this is how you're going to do it. You're going to have one hand at the base or at the bottom of the uterus, providing support. This is to prevent the uterus or the fundus from coming out or from passing or from having any type of prolapse or inversion. So we have our hand down there to provide support. The top hand is rubbing the fundus, the top of the fundus, to assess for tone. We want that uterus to be nice and firm. We want it to be right in the middle of her belly. And then here we have a picture of fundal height. Okay, so at delivery, it's at the belly button. There it is, and we would call that UU or umbilical. This would be like -1 finger width, -2, -3, and it goes down usually as mom recovers or as the days progress. Okay. So the other important thing in this immediate postpartum period is promoting maternal comfort and infant bonding. So we want to ensure that there's adequate nutrition. Help mom up to the bathroom. Okay. She should not be getting up for the first time by herself after delivery. We need to make sure that we're at the bedside with her and that we're helping her get up. We're going to monitor her emotions and provide education related to postpartum depression and baby blues, which we will talk about a lot in class and in the next couple of weeks. And then we're encouraging bonding with this infant. So, skin to skin with mom and second support person. Monitoring breastfeeding. We're looking for a good latch, which we'll talk about here. We want to keep mom and baby warm. Make sure the lights are dimmed, promote relaxation. Don't let people in the room that they don't want in the room, okay? Minimal disruptions. And then maintain our cultural considerations. Some cultures don't want to breastfeed, some cultures want to um, only breastfeed, right? Some people want to breastfeed, some people don't want to breastfeed. So we need to have all these things in mind when we're providing care for our patients. A good latch, I have a picture over here. So a bad latch, which we would call a shallow latch, would be when the baby only opens their mouth up only a little. Only the nipple is covered and the chin is not against the breast. A good latch is when that mouth is really, really wide. Most of the areola is in the baby's mouth, and then the chin is up against the breast. Okay. So those are all things that we need to take into consideration when we're taking care of our patients. Okay, so I know that this was a lot of information that we just covered. Some important things that I want you guys definitely to remember whenever we're talking about our things from this week, which we'll go into a lot more detail on um, in class this week as well. But just some key things to go over really quick. So, the 5 P's, you guys are definitely going to need to know those. Okay. So let me pull those up here. So our 5 P's are our passageway, Our passenger, powers, position, so changing positions that can affect labor and birth, and psychological. So, how is mom handling birth? Response or emotions? Does she have those previous experiences? What does her culture and the cultural influence look like? What is her support system looking like? Okay. We need to know our cardinal movements and mechanisms of labor. Okay. Know those definitions. Know what all of that means. Um, we need to know what is primary or secondary as far as like our powers of labor. Okay, definitely we're going to be reviewing fetal heart rate tracings and contraction monitors. We're also going to be talking about how to interpret strips as well. Okay. We also need to know how and what are the signs of labor. Okay. What is a sign of labor? What is not a sign of labor? Okay. So appearance of bloody show. Is that labor or not? Maybe. Or if she's having irregular contractions, they're not consistent, they're not very strong. No, she's probably not in labor. Um, has that baby drop down, lightening? That baby's coming down into the vaginal canal. If not, then no. Is that a sign of labor? Not necessarily. Okay. So, lots of things that we're going to talk about in class this week. I want you guys to review what we went over in our PowerPoint as well as kind of back that stuff up with your textbook. Okay. But if you guys have any questions, don't hesitate to reach out. And that was week 3 content.